So I'm Professor Mark Tomlinson. I'm based in the Department of Psychology at Stellenbosch University in Stellenbosch, South Africa, and I'm a visiting professor at the Department of Psychiatry and Mental Health at the University of Cape Town. So I've been involved over the last decade in running a series of community-based prevention randomized controlled trials, some to do with improving early mother-infant relationship, others to do with improving or increasing the rates of exclusive breastfeeding, and the most recent one that I've been involved in is a trial called, it's with an NGO called Philani, and this is a cluster randomized controlled trial, and what we're looking at is the extent to which we can, in partnership as a researchers and academics, in partnership with a long-standing existing NGO called Philani, recruit, train, supervise and manage a cadre of generalist community health workers to deliver an intervention to pregnant women and then to the women and their infants and children. When I say generalists, most interventions, certainly in sub-Saharan Africa previously, are quite vertical in that you have somebody who will go in and, it'll be a DOTS worker who'll deliver a TB intervention. Then you'll have another community health worker who'll be the HIV counsellor. And then there'll be a third one who will be distributing malaria bed nets. And so what we wanted to try and show was that, is it possible to develop a generalist model where one community health worker delivers a suite of interventions? So in the Philani intervention that we've now tested, that suite of interventions would included HIV, TB, nutrition, maternal nutrition during pregnancy, and then maternal and infant and child nutrition after birth, reducing alcohol use during pregnancy and after, a small component on improving the early mother-infant relationship, as well as a component of maternal mental health. So the Philani intervention doesn't screen for and then treat maternal depression in that component, but it's a core component of the general program, not the treating, but the focus on maternal mental health, and that's where this particular case study came in. So to look at what are the benefits of the Philani intervention for maternal mental health, for child development in the context of maternal mental health difficulties, and then to see to what extent can we learn lessons from the Philani approach in the context of recent changes within the South African health system, and the extent to which we can take lessons from Philani and say to policymakers, here's a generalist model which is very much in line with what you're planning, but these are the things that we believe are going to be the components that will make or break it when taken to scale within what South Africa is now calling the re-engineered primary healthcare system. Right, so our study is a cluster randomized controlled trial. So we spent about a year mapping neighborhoods in two areas, one called Khayelitsha in Cape Town and Philani, because we were very, very aware of wanting to make sure that we got our clusters, our neighborhoods very, very similar. So literally spent a year with satellite pictures of the area. We drew boundaries. We then went into those neighborhoods, and so, for example, one thing we were interested in a lot of things, but one thing we were very interested in, given the alcohol focus of the intervention and the alcohol focus of our funders at the time, it was the National Institute of Alcohol Abuse and Alcoholism in the US, was, for example, in South Africa there are a lot of shebeens, which is a local term for bars, and so we wanted to make sure that we didn't end up with one neighborhood with 20 shebeens and the next with 0. So we went in, we counted shebeens, we counted churches, we counted schools, and we matched all the neighborhoods. We then, together with Philani then started a process of recruiting community health workers. They don't call them community health workers, they call them mentor mothers. That's the term that they use. So they recruit them on the basis of them living in the area that they're going to work within, and that they're all mothers themselves, they've had children, and that with similar levels of adversity of other people in the neighborhood somehow have for various reasons managed to actually raise thriving, successful children. So that the term that's used is positive peer deviance. So there's an extensive recruitment process within the Philani model. Many more women are selected for training than are actually then ultimately hired. And the principle behind that is that you can have a lot of potential, but how you actually take up the training and then are able to implement it might be quite different. So more women will be trained, a few will be selected to actually then implement, and there'll be a waiting list for if other community health workers leave. And basically what happens is that within the neighborhood that mentor mother has been assigned, she will go and recruit all pregnant women over the course of, it was about a year. So in the course of a year, she went and recruited all the pregnant women in her neighborhood. She would recruit them. We would then, as the assessment team, which is Stellenbosch University and UCLA in the US, we would then assess those women at baseline, do a whole series of questionnaires, ask them a whole number of questions, get informed consent, and in the control areas there'd be what we would call a recruiter who would then recruit all the pregnant women in that area. And Philani worker would then deliver a series of visits during pregnancy, usually about 4 visits during pregnancy, and then following the birth of the child between 6 and 12 visits in the first year of life. The Philani model also Philani started out as very much a nutrition organization, and so they're very interested in infant undernutrition, malnutrition, stunting, and so if there were issues around that with other children in the house, for example, or when the participants of our study, became 2 or 3 years old and there were difficulties, they would then go in and intervene there as well. So probably an average of about 8 to 10 visits per family. And as I said, a generalist model, so they're doing a lot of things, not just not just HIV or not just TB. And then as the assessment team, we would then assess everyone during baseline, then about 2 weeks after birth, first post-birth assessment, then 6 months, 18 months. We've just completed the 3-year follow-up, children at 3 years old, and we're about to start a 5-year follow-up. So we've got very good longitudinal data. And why that's important is that a number of things can happen. You can have a strong effect early on that in the context of very high adversity just gets washed out. That if you don't continue visiting and give more, kind of extra doses as you go, the adversity just is too overwhelming and it gets washed out. That's one thing that could happen. Equally, you can have a good, strong early outcome. Then you do other assessment points and it seems to have disappeared, but that if you keep going and then assess a bit further down the line, then suddenly you actually see the benefits of some of that early work. They may only show themselves much later. So we're trying to, so we're doing 5 years now, and we will be looking for money to do an 8-year follow-up, for example. We haven't secured that as yet. So that's sort of the broad methodology of the study. And the teams are very much, what we do is that the Philani team, that's what they do, they're the implementing partner. They do that very well. They've been doing it for 30 years. Stellenbosch does all the assessments. We have a research base in Khayelitsha, and then the actual data analysis is actually done by statisticians in Los Angeles at UCLA. So there's 3 quite separate teams, which in a trial is quite important, because you, for example, obviously in a trial you want your data collectors to be completely blind to whether the person they're interviewing is intervention or control. Many studies often have the research side where the interventions are being delivered, and in fact, in our case, we've had a completely different research site. So in fact, some of the Philani implementing partners, and in fact the director of Philani, I don't think she's ever been to our research site in 5 years, which I think is a real strong, a strength of the whole study. And then the analysis happens again completely independently to that. So in most community-based interventions in Africa, there's very, very good evidence for a lot of different kinds of interventions. So we know, for example, that in neonatal survival, that's been one of the great successes of global health. You know, many countries with neonatal mortality rates of 70, which have now, you know, dropped to 30, you know, been halved in relatively short periods of time. There have been these huge successes. The problem with, not with those studies, but the problem with a lot of the evidence, well, there's two sides to the problem. The one is that they often are small scale, so that there were huge impacts in a small study which was tightly controlled by the researchers, and that when those successful interventions were taken to any kind of scale, then they weren't as successful. So that's the one side, is that there's this gap between sort of small scales efficacy or effectiveness studies and then the larger scale. So that's one problem with the evidence base, and we need that to be filled. And another is the issue of a generalist model, a kind of a more horizontally integrated model versus vertical silo approaches. So a lot of the evidence we have is these vertical approaches. You know, distribution of malaria bed nets has this impact on child survival. And of course, that's important. The problem is that in many of the countries that these interventions are being developed in and being implemented, have a multitude of health concerns. And so by only dealing with one, you then need an entirely different cadre of worker to do with the other risk factor, and then another group to do the third one. And so what we're trying to do here, and for this there's not that much evidence, is can you train a community health worker very similar to these other vertical models, but can you train them and give them a broad suite of tasks to deliver, and can they do that in an effective way? And absolutely central in that is the extent to which one of the main focuses, a huge focus of our intervention, of our work, is on the recruitment, the training, the supervision and the management, and to ensure quality delivery. And while the Philani study is not, in a sense, at scale, like in a province or a country, for example, it was 24 neighborhoods in 2 very vast areas. So obviously the next step would be to say, can that Philani model be scaled up into many other districts or nationally with the same benefits that we found? As I said, we've just finished the 3rd year, the 3-year follow-up, so all along the way we're busy analysing. So at 6 months, we last year published the first main outcome paper, and there we showed a number of differences across a broad range of health outcomes. So for example, there's something called the PMTC cascade, and what that is that in most countries with a high HIV burden, there's a whole series of activities that take place across pregnancy and through to the six months of the infant's life. So it would include being tested antenatally, so attending an antenatal visit, being tested, then getting the results, then if you're positive, going on to ARVs, then the infant going on to ARVs, then the testing of the infant. And what happens with the cascade is, in countries like South Africa, for example, antenatal testing rates are very high, and so your first kind of bar on your graph is very high, and then as you go down it just drops. There's this huge drop off all the way down, and that's hugely problematic. And so what we managed to do is at every single level of that we improved that cascade. In women in the intervention group, there were improvements in exclusive breastfeeding until 6 months. There were a number of benefits in terms of child illness. So there were a suite of benefits at 6 months for infant health and for maternal health as well. Currently, we're working on a number of manuscripts which show that, and this is also a big focus of the paper for the institute, was around maternal depression and is maternal depression improved by the intervention, and if it is child health improved, is child growth improved in the context of that? And basically what we found is that the intervention itself, because it doesn't directly treat depression, for example, doesn't impact on maternal depression. So the levels of depression antenatally and across the first 6 months and 12 months and even 18 months, there are no differences between the levels of depression between women in the control group and women in the intervention group. But what we did find was that amongst women who are antenatally depressed, in the intervention group, their children at 6 months are heavier and longer. So there's a significant growth benefit for those women compared to antenatally depressed women in the control group who didn't receive the intervention. And in addition, in the same group of women antenatally depressed, at 18 months there's an impact on child cognitive development. So that the children at 18 months, the toddlers at 18 months of women who were antenatally depressed but who received the Philani intervention, they're doing better on the Baileys than the toddlers of women who were depressed antenatally but in the control group. And that's an interesting finding, because it's the levels of depression aren't different, but there's an impact somehow of this generalist health model working through the mothers to a benefit of the children. Now obviously the fact that there isn't a benefit for maternal depression is important, and that needs to be the next step. So colleagues of mine in Cape Town and I are thinking about, a colleague of mine, Professor Craig Lunt, is involved with developing a model of using community health workers to actually identify and then treat depression using community health workers. And if that is successful, and we hope that it will be, the next step would be then to take that kind of the identifying the treating of depression, and see whether you can integrate that into the existing generalist model of the Philani community health workers. Obviously, there are implications there. You know, one of the big issues we have is that globally, community health workers are sort of increasingly being seen, certainly in poor countries, as the solution to all health problems. And so whenever there's something like the nurse can't do because they're already overwhelmed with work, or there aren't enough nurses or whatever, we'll just give that to the community health worker. And so they've been given an increasing number of tasks. And we would argue that there's a limit to that you can't keep just adding on extra tasks, and that at some point, you know, they'll be still delivering certain things, but other things are just completely being ignored. And so that would be because, you know, treating depression, I think, is a very particularly, we know it can be done, we know it should be done, but it's also, it requires a particular kind of technical skill, which I have no doubt that community health workers can be trained to do. I have no doubt about that. The extent is to which they can be trained to do that, and then the suite of 7 other things, and do all of them effectively. And that's one of the things we desperately need information, data about, to see whether that can be done. So in the South African context, where the South African government is really trying to move towards a re-engineering of the primary healthcare system, using outreach teams which use community health workers together with professional nurses and teams to deliver services at household level, I think that the lessons are enormous. The most important lesson is that community health workers who are, you know, recruited in a particular kind of way, who are well trained, who are supervised well, and who can deliver a suite of interventions and can do so effectively with quality, and that they can improve maternal and child health outcomes. So that's a huge, I think that's an enormous message, a very vital message for policymakers. More importantly, even than that, I think, because we know there are a lot of packages out there, we know they can be done. The fact that ours is generalist, I think, is as I said, is something that I think is quite unique. But I think even more importantly is that what I mentioned earlier is that when things get taken to scale, which is what the South African government wants to do, when they're taken to scale, they fall apart very often, because what happens is that for want of a better term, the boring components get dropped off. So Philani has weekly supervision, weekly group supervision. It has a whole series of which is emotional supervision, which is supportive supervision, have a whole suite of administrative components to supervision. Often what happens, and this would be my worry, that the model will be taken, and because of cost constraints or whatever, the first thing will get dropped would be, we don't really need the emotional supportive supervision, so let's drop that. You train for 3 weeks, it's too long, we can't take people out of the system, so we'll make it 2 weeks. And so all these things start getting cut off and dropped off for often very good reasons, for human resource reasons, for cost reasons. But the moment you do that, I think that's when they fail. So the extent to which we can develop, test, and effective models of supervision, management, training, recruitment, and make sure that those remain at scale will be I think will provide huge important information for policymakers. And maybe just to also say one thing, I do think that our findings are not solely relevant to South Africa. So the Philani model currently, through support from the Church of Sweden, is actually implementing this model, this mentor mother model, in Swaziland and Ethiopia, and there are talks of doing it elsewhere as well. So I think it has enormous lessons for a much broader kind of number of countries, and not just South Africa.